Okay, so our first question. This one is for Isabelle. So this was from Seema. Was there a marked difference in how you were perceived or treated in primary school versus secondary school that you feel might have contributed in some way to worsening of your asthma symptoms during your teenage years?
I mean, I don't think there's necessarily anything specific to pinpoint. I think it's more the difference. So in primary school, you're very much cared for by either your parents or then your teachers in that school setting. So anything that gets picked up on is kind of dealt with. I think in secondary school, it's a lot more different because of the environment that you're in. And I think it's a lot more to do with that environment. I think in terms of my symptoms and how they progressively got worse, I think I don't really think it had anything to do with the two school settings. I think it was more external factors that kind of fed into the deterioration of that. Well, that's what I've been told anyway. So that's why I'll go off.
Yeah, I think that's right. So I think certainly in your case, from what you've described, that clinical element. I mean, do you think there was from a sort of stigma perspective, do you feel that there was a bit of a difference from how you were perceived by your peers as you got older? Do you think there was a kind of sensitivity in teenage years, or kind of bullying or more negative impacts in some ways as you enter those teenage years? What's your thoughts around that, for your experience?
Yeah, so there was definitely a difference. I'd say in secondary school, it was honestly brutal. That's probably the best way I'll describe secondary school in terms of that. So I definitely hid it a lot more, and I would get frustrated because of that. So I would never take my inhaler in class or in public. I would excuse myself to go and take it. But it even got to the point that I wouldn't tell the teacher. So I'd tell the teacher that I wanted to go out of the class for a different reason, which in itself seems stupid, because if I was struggling, it would have been better to have told the teacher I was struggling and needed help, rather than taking myself out to be on my own somewhere. And I'd go and find like a random corner in the school that no one would pass to take my inhaler, because I felt embarrassed to take it, or embarrassed to be seen to be taking it in secondary school. Whereas I think in primary school, actually a lot more of the kind of opinions came from the teachers and not the other children. So that was more to do with like being excluded from sports sessions, and kind of being told to sit down, or like in my case, I didn't get to go on certain school trips because they decided that with my asthma I couldn't go on them for some reason. So yeah, I think the difference is who it actually came from, who was informing those opinions between secondary and primary school. No, primary and secondary school, I've gone backwards.
Yeah. Okay, thank you. So the next one, again, this is we'll start with you for this one as well, Izzy, as well. So I think this a question was, what do you think we can do as healthcare teams and wide networks to rebrand asthma? Because I think you were talking very much about sort of messaging. And I think there was a later question as well, which is something about trying to walk that fine balance between raising the awareness and saying how important asthma is and how it is a really significant illness, whilst at the same time not stigmatizing and making it look like people who have asthma are somehow weak, or some of the other words that you put up during your presentation. So what are your initial, do you have ideas? What could we as a system do differently, do you think?
I mean, I think.
Yeah, we can hear you. Don't worry.
Oh, okay. So I think in terms of what can like be done. So I found that when I go, so part of the role I do, I go around a lot of primary schools and secondary schools, and I speak to the children, and that's where I got a lot of the words came from sessions I worked with them. So a lot of it was actually that they didn't understand really anything about the condition, and then once they understood, they realized that the stereotypes and the images they'd been fed kind of fell apart. I think in terms of healthcare, from the healthcare side, it's more about making the person with asthma. I felt that once I felt more confident in my asthma myself, or I felt like, you know, it could be managed and it could be controlled and it wasn't going to kind of like take over my life and I didn't have to hide it. That then made me feel a lot more confident about it. And I think it is definitely a fine line. And I did read that there was a comment saying that if your asthma is well controlled, you are symptomless, so you shouldn't be able to see it. So how do you portray that in imagery? And the whole point is that you shouldn't have to. I think we just need to kind of remove images where we're naming people by symptoms like wheezy or something. And we're making it more a positive attitude that asthma is around, and it's just more like a message of, if you have asthma, have your inhaler, rather than this big dramatic display of someone having, I don't know, like an asthma attack or something negative that can be drawn to asthma. Whereas in other conditions, it's kind of just like a reminder that if you have asthma, to do, like, if you have that condition, take those steps. I think we kind of need to detach from just feeding people the big dramatic displays. And I think it's going to be a long process because the kind of stereotyping and the images people have asthmatics have come from decades and they get passed down. But I think it's not overfeeding them either and kind of completely converting it, because with any kind of, when you're trying to change an opinion on anything, it can't kind of happen overnight and you have to do it kind of in baby steps. But yeah, that's probably, I'm not entirely sure if that answers the question or not, sorry.
Well, it certainly gives us your view as well, so that's appreciated. Jen, do you have thoughts on that?
I think, I mean, Izzy, your presentation was fantastic, and it's just so good to hear the perspective from your point of view. I think the perceptions of asthma and the stereotyping are, like Izzy kind of alluded to, at different ages, and I think the way that's tackled has to be specific to the different ages. So I think, you know, social media is so important to those younger age groups, and even just having some influencer who has asthma, that would possibly, you know, affect significantly people's perceptions, but that will be different for the older age groups and for like teachers and sports coaches. And I think we probably need to have different ways of doing it for the different groups.
Yeah, and I think so I think this is going to be an ongoing thing. If you again, so keeping this interactive and sort of sharing ideas, do please, for those listening, drop your ideas into the chat, so that we can kind of share what's worked and what's being done in other places. I know there was an instance where in terms of influencers, it's also important to make sure that the influencers are giving the right messages. There was a piece of work we had in that was being done in North Central, where we had a professional footballer who was very keen to support us and give a good message to support us with young people with asthma, but actually message they were giving about how they look after their own asthma was not the message we really necessarily wanted to be sharing in terms of appropriate use of treatment, etc. But then we were able to support them with advice, which I hope will change the advice they give in the future. So it can be interesting. Thank you. So let's move on to our next question. This one is for Sylvia. Is there a way to determine deaths purely from asthma versus asthma with an allergic reaction? And does this relate to the differences between UK and other countries? And also, to what extent do you feel that that's an important distinction to make?
Yes, yeah, thank you. Yeah, that's a very good question. So Karen mentioned at the end of the presentation that the report we will be publishing will also cover a section on anaphylaxis. And this was on purpose because of the very close link there between children with asthma and allergies, and the fact that some children die due to their allergies as well. So we've included this separately because the cause of death there is due to the allergy. So it is anaphylaxis and not asthma. So there is a clear distinction there in the cause of death. So when we talk about deaths due to asthma, this is where the PM report and the coroner's inquest conclusion is that the death is due to asthma as the underlying cause of death. For the deaths due to anaphylaxis, there's clearly anaphylactic reaction And that's you know, in the post-mortem report, and again the coroner's inquest conclusions will also make that distinction clear and record that in the record. And this is how we've done it. So we separate deaths due to asthma and deaths due to anaphylaxis. So in some cases it's not very clear, as clinicians on the call are very aware. It's very difficult to separate, because there is a very close interplay there. But we have validated these deaths with clinical experts, both in asthma and a fatal anaphylaxis, so we can publish the numbers there, and people can see more information on that and the methodology when the report is published. But the main thing is to recognize allergies as very important risk factor for children with asthma.
Yeah.
And for this to be recorded in the medical notes, and both to be addressed as part of the asthma care plan. This is what's coming through with the report.
Yeah, very helpful reminder about that, Sylvia, because I think if we look at asthma action plans, we do see triggers mentioned always on all of the asthma action plans, and I wonder how often those are actually discussed or addressed in consultation. So it is important. Okay, so next question. This is so the question is, how much do you think about your indoor air quality? So I think Izzy, really, I suppose, as the as the person representing all people with asthma on this panel, I'm going to start with you, and then we can expand it out to colleagues as well. So how much do you think about your indoor air quality? Has that come across your radar?
I mean, yes, it has. I think it came across my radar potentially earlier than from other people with asthma, based on what I researched. So it's always, air quality is always on my mind. But I mean, in terms of my asthma, it did, but not until I actually started having kind of like my severe asthma attacks, and it kind of got messy in that when we were trying to pinpoint my triggers, and air quality became a factor that we were considering. And then I kind of moved into getting like an air purifier filtration system that I now have, because a lot of the different particulates kind of influenced it. So it did become a factor, and I now am very conscious of it. So I will walk into a room and then turn and walk out of a room if I notice something. And I think a lot of time we put a lot of focus on outdoor air pollution to do with cars and stuff, but I think we don't necessarily look indoors, whereas that is a lot of the time where we spend a lot of our time, especially I spend all my whole day in my room working sometimes. So it's definitely something that I focused on because of my settings, but I don't think it's necessarily a factor that generally people with asthma consider. I think we're more focused on external factors and external air pollution rather than internal.
Thanks, Izzy. And again, Jen, I think one for you, your input.
Yeah, I mean, I think historically the importance of indoor air quality has been underappreciated, and I think we all have a role as healthcare professionals to be more aware of that, and also to pass that on to our patients so that they are more aware of it and can advocate for themselves. There has been, it is improving, I think, with AWAB's law and with the guidance for landlords now, the national guidance for landlords from the government. There's sort of a blueprint of what should be happening and what should be acceptable and not acceptable. And I think we just need to always ask that question, raise that as a potential issue with our patients, tell them that they have rights, and that according to AWAB's law, they should know that what those rights are, and that according to the national guidance from government, that there should be a way that every housing agency should have a pathway of communication between health and housing, so that we can alert them to issues with tenants and indoor air quality. And I think we just need to keep that conversation open and make sure that the awareness is with our patients.
Yeah, thank you. And I think it's I suppose on areas as well, and ICB networks, to think about how they can how they can build that in. So, you know, if you're creating templates for your extended asthma reviews, for example, putting in questions as a reminder. And then also I'd ask anyone who, I know a lot of different areas have spent time creating resources around to give to patients about indoor air quality. Jen, I think you got stuff on Beat Asthma about indoor air quality. I know certainly London programme has, so we're happy to post those links into the chat. So for those of you who are interested, this is all freely available and you can give them to patients. Jen, Mursheda, this is one for the national team. Is ARTP accreditation a must for CYP spirometry? Up until now, this hasn't been very clear, and none of our teams are accredited.
So at the moment, it's not a must, but it's sort of on the horizon that it will be. But when that will happen, I don't know. It keeps getting pushed back. It's just strongly recommended. And this is just to ensure that any spirometry that is performed is quality assured and is as reliable as it can possibly be. So not you have to, but really, really recommended that you are.
And I think Jen, sort of as a follow up more broadly, you know, this is a similar situation with the tiered capabilities and the question about mandatory training. Have you kind of got a national view on why it's not mandated?
So I think the fact that it's not mandated is a barrier at the moment. I think you sort of need that to make sure it's prioritised. It's a hope. I don't know if it is achievable, but certainly I know the regulation 28 that was issued following the death of
have we lost? I think we've lost Jen. Oh, are you back, Jen? Go on. You said we got as far as section 28.
Oh, I think she's frozen.
Let's see if she comes back, because I think she's referring
To William Gray.
Yeah.
Yeah. Can you hear me now? Sorry about that.
Yes,
can you hear me?
Yeah, we've got you back again, Jen.
So I was just saying that there was a regulation 28 that was issued last year following the death of William Gray, and in that the coroner wrote to the Secretary of State for Health and expressed her concern that one of the areas of concern was that this training isn't mandated. So who knows in the future whether it can be, certainly by putting that STIP in the NHS standard contract that raises the priority level. I think if it has to be realistic, and in the current climate, I think particularly in primary care, there's so much asked of primary care professionals. If something's going to be mandated, it needs to be an environment where it's realistic. So I think there's work to be done to get to that level, but absolutely recognise that the fact that it isn't mandated is a barrier.
Right. Thank you. So Izzy, another one for you. What advice by a health professional did you find most useful in your asthma control throughout your journey?
I think probably the most useful advice I got was to actually be honest. So for so long, because I decided to hide my asthma and symptoms, I used to go to my review and just in primary care before I got referred to secondary care and just say that everything was fine and everything had been fine. And it hadn't. And I think it took me a while to actually realise that that wasn't actually helping anyone, and definitely not me. So I think the best advice I got was to be honest with healthcare professionals and just anyone about my asthma and how I was feeling. And it all came down from being embarrassed and ashamed of having my asthma, and it kind of just spread across every sector in the end, not just school. But then after that advice, I did definitely feel more like aware and open. So then I would share when I was having bad days, and then we were able to kind of like build a story of what was happening with my asthma and could then pinpoint where we'd noticed things were going a bit off. So that was probably the best advice I had, and it's kind of the advice I give to other young people I speak to who I know are like me, and we walk into an appointment, say everything's fine, and walk out. So our appointment lasts 30 seconds, but we didn't actually cover anything. So yeah, that was probably the best advice I got. And also to follow up was that I shouldn't feel that I'm excluded from anything because of asthma. So I should try everything first and then decide whether I can or can't do it after trying it, and not just decide before I'd even started.
Yeah, that's really interesting. I would never have thought of that as a good piece of advice. And I think even in the chat, as you from your presentation, a lot of people you've given people a lot of ideas about how to approach these conversations in the future, and that's another really good one. Thank you. There's one for Mursheda and Jen, or either of you. Has anyone had any success or considered how to support ambulance services to access CYP asthma training? Who wants that one?
I haven't heard of any. Mursheda, have you?
I haven't. I mean, we have the training capabilities framework, and we have the training on the e-learning for health platform for everybody. We want asthma to be everybody's business, so we want our systems to cascade the learning to all health professionals within their localities. And please do disseminate those links and the value in taking up those training sessions. So as Jen has mentioned, we've got a high uptake for our tier 1 training, but our tier 2 and our tier 3 is where specialist sort of health professionals can be trained in what to do, particularly in relation to exacerbations. So would really benefit ambulance staff. So please do circulate the training widely within your localities, and we can share the link again to everyone on this call today, so that people can disseminate as widely as possible.
Can I just add? Sorry, Jen.
Go on, Sylvia, and then Jen.
I just wanted to say that we are making a specific recommendation on the training for all professionals, exactly for that reason, and what we're seeing in the death reviews, and we are including all the links to all the training materials there with this report. It's a national report, learning from child deaths due to asthma. By all means, all professionals, all networks can use this report to disseminate the learning and what needs to happen next. So just wanted to add to Mursheda. Thank you.
Thanks, Sylvia. Jen?
Yeah, it was just sort of build on that really, because I think that previously I have spoken to our local ambulance teams, and it was an issue around prioritisation again. They only had a set number of days for training in the whole year. There was so many conditions. Why should they prioritise asthma? And these reports recommending that this training is mandated or is essential, I think they're all going to give us leverage so that asthma becomes that priority area in all these different areas.
I think there's and from experience working in London, certainly London Ambulance Service are very happy to engage with networks, and I think there's things that could be considered as well. So not just training, but the role for the ambulance service in what to do and who to speak to if a child does have an asthma attack. So is there a way that services can be encouraged to support contacting primary care, as an example, if they're looking after, if they do attend for a child with an asthma attack? Is there a phone call through to a GP in their circumstances? So there are things that could be broadening, going more widely. It's the pathway as well as specifically the training, I think, that we can think about. We've got 2 minutes and quite a punchy question. I think this is one about FeNO, with the new draft guidance and the importance of FeNO in the new draft NICE sign guidance as initial diagnostic test. Is there going to be financial support implementing this? And in addition, how will this affect the CDC bids? It's a hefty ask. Can you do it in 30 seconds, Jen? Mursheda?
And what I would say is that this is a hot topic that is being discussed as we speak. absolutely recognise that if in order for children and young people to be able to follow this diagnostic guidance, they need to have access to pheno, and either that's going to be locally or from hublets or CDCs. So all I can say is we're working on it.
Yeah, thanks, Jen. And I think there's probably, for some people who also have a view, I think there's also questions in the NICE guidance about the value of pheno as a diagnostic tool in asthma compared to spirometry, and we kind of recognise that that's an issue which we're not going to get into in this conversation, but do recognise, so just so that everyone's aware. There was a question in the chat which I'm not going to pose, but just to sort of flag. So there's a question about, is there a plan to lobby government regulators reproducing MDI inhalers with dose counters? I don't think there is a specific plan, but I think from what we're hearing today, there's lots of evidence to lots of different pieces of evidence that we can use to support that. I mean, certainly at a national region, I'm sure the team are doing something. We at a regional level in London would be happy to coordinate something like that through LALIG. Jen?
Yeah, sorry, I just want to jump in there. The MHRA have prioritised this as a serious patient safety issue. So I think I almost think it may not be needed. So we just need to watch this space on this one.
Okay, that's really helpful. Thanks for reminding me of that. You did say it earlier. Fabulous. All right, so that brings us into the break. Thank you so much to our first session speakers. Really grateful for you all being here and for the contributing to the panel discussion.